Good morning and assalamu alaikum, everybody. I would like to welcome you all to the Gynae Oncology session in 21st Shaukat Khanum Cancer Symposium. Thank you everybody for joining us over here. I would like to thank our speakers for taking their time out and being part of this wonderful educational activity. Dr. Mazhar and I'll be chairing the session today. Dr. Mazhar has kindly agreed to co-host the session with me. So we'll start with our first talk. Our first speaker for the day is Professor Zeba Aziz. And everybody in Pakistan who has worked in oncology knows that she needs no introduction. Dr. Zeba has played a great role in shaping the future of oncology and current practices of oncology in Pakistan. And I would like to thank Professor Zeba personally and on behalf of Shaukat Khanum for being part of this educational activity. And she'll be talking about advances in treatment of ovarian cancer.
Thank you. Thank you. Good morning, everyone. I would like to start to talk about ovarian cancer. Probably you all know how to treat it and how to go about it. But I found that when I was working, when Tabinder told me that you have to talk on it, I found that I really needed to learn more, despite treating so many ovarian cancers and even in the first line. And I would like to thank Tabinder for letting me learn a bit more about ovarian cancer. So let's start. And this is a 56-year-old female from my clinic who had no comorbid conditions, and she presented with 5 months history of vague abdominal discomfort, 3 months of constipation on and off, abdominal distension for 15 days. Ultrasound revealed moderate ascites at an axial mass and a thickened peritoneum. Her CA125 was high. We sent her cell block for cytology, which revealed high-grade serous adenocarcinoma. And basically, after all the workup, she was staged as stage 3C. Now, you all know that more than 60% of our patients present with advanced disease, and stage 3C is one of the most common things which we look at and which we see with our patients. Now, when we decide that how to approach this patient, we just don't say, okay, she's 3C, let's start treating her. You have to look at several things which are important before you start treating the patient. And some of them are the comorbidities, which could be hypertension, diabetes, history of DVTs, anything else. You also have to look at the surgical outcome. The patient, can she undergo surgery or not? And the idea of surgery is not an incomplete surgery, but an R0 resection. Because without an R0 resection, there's no fun in having surgery. So while you're seeing the patient, you're also assessing. A good clinician or a medical oncologist would also assess these things at the same time. So as a medical oncologist, if she comes to you first, you have to decide, should I send her to surgery or not? And believe me, there are very few trained gynecological oncologists in Pakistan. I can count them on my fingers of who they are and where should I send the patient. And will they be able to resect everything or not? Then while we are doing the surgery and after surgery, you have to look at the morphology, and the grading of the tumor is also important, histology and grading. You also do a FIGO staging, and you divide the patients into which staging group care. And most importantly, now you have to look at the genomic profile. We all know that the genomic profile is, in modern day, if a patient can afford it, we have to look at it. So while we are doing this, I decided that this patient, and I talked to the surgeon, that she was inoperable and he would be unable to do an R0 resection. So if you look at the data, this is a long time ago. We were practicing neoadjuvant chemotherapy quite a while back, but like everything else, Tabinda, I'm taking time so that you're talking. Anyway, like everything else, we never had the courage to come forward and say, let's write a paper on it. This paper was published by GOG in New England Journal of Medicine, where they looked at about 500 patients and they said that, do we need to do primary surgery in all patients? Or should we do neoadjuvant, like sandwich the surgery in between after 3 cycles and see if the survival is different in patients who undergo primary surgery versus those who do not undergo primary surgery? And when they looked at the 3-year overall survival, and it was basically similar. They looked at the median overall survival. It was similar, and progression-free survival was similar. If you look at the graph there is no difference between the overall survival and progression-free survival. And the goal of surgery should always be R0 resection. Now, if you can't do R0 resection upfront, there's no point in doing surgery, and it is better to be conservative. It is better to err on the side of conservatism and say, okay, I don't have a good surgeon. Like if somebody's working in a district hospital or working somewhere where you do not have good surgeons who can do R0 resection, and you can't, and the patient cannot come to a tertiary care center, let them have neoadjuvant chemotherapy and look at the survival. Now, when I started my practice, we were giving cisplatin and cyclophosphamide as the treatment for ovarian cancer. Now, this is not so nowadays. Nowadays, the standard of care is carboplatin and Taxol. Now, why have I put this slide up here? This is the ICON 8 study, which looked at progression-free survival. And basically, if you look at the first table is standard every 3 weeks. You're looking at weekly Taxol and you're looking at weekly carbotaxol. And what you find is that there is no difference between all the three. You can give a patient a standard 3 weekly cycle. You can give the patient a weekly cycle. You can give it 2 weekly, 1 week. Idea is to give the full dose there. Now, if you look at the median progression-free survival, it is the same. Several of our patients don't tolerate the 3 weekly cycle, and you have to go on a bi-weekly or a weekly. And several patients who come from far off, they would prefer a 3 weekly cycle. Okay. How do we treat a patient? We've given them 6 cycles, we've done surgery, patient has a complete response like ours did. And how do we put them on maintenance? Do we not put them on maintenance? How do we manage this patient? The CA 1 to 5 has resolved. What do? We know by experience and we know by data that 75 to 80% of these patients will relapse even if they achieve a complete response. And every time I see an ovarian cancer patient, believe me, even now my heart skips a beat that they are coming with relapse, because that is the worst thing they can undergo. And our patients are generally younger, around 55, 60. So basically what you're looking at, if a patient does not respond in the first 6 months of therapy while he's getting platinums, that is a primary refractory disease. So there is a difference between refractory and resistant. In the resistant disease, the patient gets better response, and then within 6 months, the disease comes back. That is a resistant disease. And when it comes later, it is platinum sensitive, whatever, it comes back. So basically, for the longest of times, we were just doing 6 months of therapy and saying, okay, go home and we will follow you. So then what happened was, we wanted to see if there was a role of maintenance therapy or not. So this is the GOG 218 and ICON 7 trials, which looked at bevacizumab and the role of bevacizumab in induction and maintenance therapy. Now, with advanced ovarian cancer. So there were 2 groups, one with placebo and one with placebo meant that there was no bevacizumab and the other group had bevacizumab. And if you look at the 218, there is a stomach in between, which shows that the progression-free survival was 14.1 months versus 10.3 months. And again, in the ICON 7, there was a difference in progression-free survival. These trials validated the benefit of concurrent maintenance, concurrent and maintenance bevacizumab. But should we use it in all patients? I don't think we should. I think it needs to be used, and this is what the trials proved also in high-risk patients with lots of ascites, because as you all know that bevacizumab is a VEGF inhibitor and it inhibits the formation of new blood vessels. And ascites, when you have ascites and peritoneal disease, there's a lot of new blood vessels there. So that is where the role of bevacizumab is. In poorly chemosensitive tumors, like if you find that she's not responding as well as you expected, that is where then there is a Kellam score. I'm sure all of you know what a Kellam score is. It is a slow fall of CA 1 to 5, and you calculate it after each cycle. if you find that your CA1 to 5 is not falling as it should, you find that the disease is not responding as it should, bevacizumab has a role, and it improves both progression-free and overall survival in this group of patients. Then there was a question after all these trials. You look at the GOG 218, I talked about ICON 7, ovarian 12, Aurelia, Oceans. All these trials showed a benefit of progression-free survival, but no trial decided that what is the length of bevacizumab? Should we give it indefinitely? Should we give it just for 1 year? Should we give it for 12 months? Should we give it for 5? What should we do with bevacizumab? So this is an AGO ovarian 17 boost study along with ENGOT ovarian, where they looked at 15 months versus 30 months to see whether 15 months would be enough or not, or do we have to go for 30 months? And the median progression-free survival for 30 months was 26 months versus 24.2. So basically what we now know that 15 months of bevacizumab, concurrent and maintenance, is enough. You don't need to give more. And then you follow these patients. And you know, whenever we do something, and I would encourage all of you young people to do clinical trials and see what is happening. And especially in patients who are in our part of the world where the resources are very limited, and we have to look at our resources because the patient is spending out of their pockets. Look at the data and see what is happening. This is another trial. I'm not sure any institute in our country is doing it or not, but maybe Aga Khan or Shaukat Khanum, one of them is doing it, but this is hyperthermic intraperitoneal delivery. And this is to allow the better penetration of residual tumor cells. Heated chemotherapy increases tissue penetration and causes apoptosis of DNA and everything. The overall survival was improved by 12 months by HIPEC without an increase in high-grade complications, but it's a tough one. So I'm not sure if we can practice that routinely in every center, but one or two centers, if they want to do it, can do it. Now, this is the story of PARP inhibition in ovarian cancer. And it is mainly related to the BRC mutated and hormone and the HR deficient or ovarian cancer cells. Now, if you look at the normal cells, remember for a moment that all of our cells are dividing. And when our cells divide, we replicate the DNA and normal daughter cells are produced, right? However, during replication, remember that sometimes the DNA gets muddled up, stuck, or gets damaged, and that cell will survive and become a cancer cell or die over the long term or give problems for that person. Now, we have natural enzymes, which are the BRCA enzymes, and we have the homologous repair deficiency enzymes, which are ATM, other ones RAD52, and what the BRCA does is वो एक जाल बिछा देता है जिसके ऊपर the other enzymes come and repair the double-stranded DNA. Now, two types of DNA breaks can happen during division, cell division. One is a double-stranded, and one is a single-stranded, right? क्योंकि हमारा DNA डबल होता है ना इस तरह करके, तो एक या यहाँ कट होगा या दोनों में कट आएगा. So, जो दोनों में कट आएगा, BRCA genes and the ATM and RAD51 will repair that. But if it is a single strand breakup, the PARP's mediated repair takes place. So, अगर आपके पास आप एक normal person को like who does not have a BRCA deficiency, you give PARP inhibitors, it generally doesn't work. Generally, it won't work because आपका double-stranded DNA is responding and you have the normal BRCA genes, you have the normal things which will repair them, right? Any questions on this? Achha. So if a person has a germline BRCA mutation or a somatic tumor BRCA mutation, over there, the double-stranded DNA will not repair. Now, PARP will try to come in and do the single-stranded DNA repair. But if you inhibit the PARP, just remember कि ये चार टांगों पे खड़ी है ना, मैंने 3 टांगे तोड़ दी तो ये टेबल गिर जाएगी, right? तो अगर ये BRCA की टूटी हुई है, 1 टेबल 2 टेबल हमने तोड़ दी तो ये गिर जाएगी. So that is what is happening between PARP inhibitors, which work when you're BRCA mutant or you are homologous repair deficiency. And the homologous repair deficiency is that the BRCA are normal, but the other genes are defective, so you will not be able to repair these. So the first trial for PARP inhibitors was the SOLO-1 design trial, which consisted of olaparib 300 milligrams versus placebo. And what they did was they only took patients with germline or somatic mutations. The somatic mutations mean that the patient does not have a germline deficiency, but the somatic cells or the tumor cells will have the BRCA deficiency. And they stratified these patients and they looked and they said, let's see what happens. So there were about 400 patients, 260 in the olaparib arm, because it was a 2-to-1 randomization. The primary endpoint was progression-free survival. And 2 years of treatment was given if patient had no evidence of disease. Look at this. This is a beautiful curve. You normally don't see it. What you look at, the median treatment duration was 74% versus 35%. And the effect of olaparib, even after 2 years, carried on. So if you look at the 5-year follow-up, you still have nearly 50% of patients alive in the olaparib arm versus about 16 in the other arm. And if you look at the median progression-free survival, it is 56 months with olaparib and 13 months without olaparib. So basically, these SOLO-1 trial only included germline BRCA mutation, or they included somatic BRCA mutation. This is another trial, which was with niraparib, again 2-to-1 randomization. Key endpoint was progression-free survival, and patients were stratified according to NACT, which is neoadjuvant chemotherapy, CR or PR after platinum chemotherapy, and they also looked at the HRD status. And what they did was the progression-free survival was tested separately for the HRT deficient patients and separately for the overall population. And these are the baseline characteristics of the primer study. 35% of patients were stage 4, 99% or over nearly 100% had stage 3 residual disease, 67% received NACT, 31% had a PR, and 51% had homologous repair deficiency, while 30% were mutant. 34%, please keep this in mind, were HR proficient, which meant that their PARPs and everything was normal. They were a normal population. The progression-free survival benefit was still there when we looked at this 38% reduction in the hazard risk of relapse and death. And median progression-free survival was 13.8 months versus 8.2. And patients without 6 months, it was 73, 60. You can look at all this data. Now, if you look at the HR deficient patients, that means that their enzyme, BRCA was normal, but the homologous repair enzymes were abnormal. You find there was a 57% reduction in the hazard of relapse. This is much higher than the overall intent to treat population, because over there you had normal people also, right? So here we just taking these patients and saying, okay, is there a greater advantage? And if you look at this, the median progression-free survival was 21 months versus 10 months. Now there's a difference of 11 months versus here, where there is a difference of about 6 months, right? So has a HR deficient population will benefit from PARP inhibitor. Now, this is again the primer in HRD deficient, HRT proficient subgroups. So the first one is when they are both mutated, the BRCA is mutated and one of the other genes is also mutated. And you have both BRCA mutation and you have homologous repair deficiency mutation. And look at the difference between the progression-free survival. The second middle curves show patient has a homologous repair deficiency, but the BRCA is not mutated. And the third is the overall population, overall people who have no deficiency, either BRCA or HRD. And over there, the curves are nearly normal. There's still some progression-free survival advantage, but the hazard ratio is 0.68, and you see the curves are intermingling. Here, with both of them, either if you have a BRCA deficiency, BRCA deficiency or BRCA HRD, you will see that there is a difference in curve. Now let's change gears and look at the Paola study design. What they said was, okay, we are giving olaparib to patients who are, or niraparib to patients who are BRCA negative, mutated and HRD deficient. What about bevacizumab? What is the role of bevacizumab in these patients? So what they did was they looked at this and they took all the newly diagnosed high-grade serous endometrial carcinomas and they gave 2 years of olaparib and they gave bevacizumab. And in the other arm, they gave bevacizumab alone. The progression-free survival with olaparib plus bevacizumab was better than just bevacizumab alone. This is HR deficient and other population. Now, when you look at the HR deficient population, you find that if you are HRD positive and you include the BRCA mutation, your progression-free survival is 66% versus 30%. There's a marked difference in the progression-free survival. If you look at just HRD positive, again, there is a difference. But if nothing is mutated, there is no survival benefit. I hope you understand. It's somewhat complicated, but okay. So how do we interpret this? Because what we are saying is that in the BRCA mutated, in the solo one, we had a survival difference. In the GOG 218, we again saw a survival difference. And in both of these, we were using olaparib. Now in Paola 1, the survival difference is the same. And do we truly need bevacizumab in these patients or not? That is what the question was, that is there a role of bevacizumab along with PARP inhibitors in mutated tumors? What we can say is, we cannot say that olaparib plus bevacizumab is the best option for BRCA-associated tumors based on this trial, but we can see that the benefit of bevacizumab is additive in these patients. And in patients who you have already started on bevacizumab and you get the germline mutation later on, you continue with bevacizumab. That is all we can say right now. We cannot say that Bev plus olaparib is superior to Bev alone or olaparib alone. We can say that if you have started it and you get a germline or a somatic mutation later on, continue both. Okay. So what is the best option for HRD positive tumors? You have the Velia trial, which is rucaroparib. You have the Primer trial, and you have the Paola trial, all showing a benefit of progression-free survival. Now, ASCO gave a rapid update on these PARP inhibitors in June 2022. And this is where a lot of things came into place, and you may or may not disagree with them. In newly diagnosed patients, in CRPR to first-line platinum-based therapy, PARP maintenance should be offered to patients with high-grade serous adenocarcinoma with germline mutations or somatic mutations in 1 or 2 genes. You can give olaparib, rucaroparib, or niraparib for 2 or 3 years. In HRD positive and non-BRCA mutations, the latter 2 drugs have been approved because even though they're all the same, but olaparib was not formally studied in this. So basically they're all the same, and this is the strength of evidence. In the second line or greater therapies, maintenance treatment of PARP may be offered to patients who have not received PARP inhibitors and who have responded to platinum-based therapy regardless of BRCA status. Treatment is continued until progressive disease or toxicity despite this. Now, basically, progression-free, so when patients relapse and have ovarian cancer, it's one of the most difficult diseases to treat, and you really can't help the patients that much. They get better for a few months and they come back with relapse. So what do you do with these patients? These are the things which we have to look at. PARP inhibitors should not be routinely offered for the treatment of platinum sensitive, and this evidence, because they say the harms are more, and you have to discuss individually and discuss it with the patient regarding the risk, benefits, and preferences. If you have platinum resistant disease or you have BRCA wild type, do not recommend PARP inhibitors for therapy as a single agent. So this is a biomarker defined decision tree for first line therapy of ovarian cancer. Look at the arrows. We give carbotaxol plus minus bevacizumab. And before that, we decide neoadjuvant versus adjuvant therapy versus primary surgery. We do the molecular genomics. And if you have a molecular germline BRCA1 or tumor BRCA1, we divide it into BRCA mutated, we divide it into BRCA mutated and wild type HRD, or wild type, everything is all right. So this is how we give the drugs, and this is how we decide what has to be done. I think this is the end. I haven't gone into IOs or anything else because this was more first line, but if there are any questions.
Thank you very much, Dr. Grivo. This was an excellent presentation on ovarian cancer. And I hope that our residents and doctors have learned from it a lot. Thank you so much. If there's any questions, you can ask now or you can ask at the end of the presentations.
I think it has to be checked routinely. It should be checked routinely. The problem which I'm encountering is I have not had a BRCA positive when I send it to Shaukat Khanum. I'm not sure why that is true. And I would like to ask the pathologist, why I'm checking quite a few. I think 30% of my patients do get checked who can afford it because we want to put them on a lab prep. The problem also is like, if I'm doing a germline, is there a way I can test somatic? It makes things more expensive. Germline is about 80,000, and then I'm not sure how much the somatic is and whether they are doing it or not. So these are the problems which I, as an oncologist, am facing. I'm not sure about others, but I try to check them as much as possible. We generally now doing much more than before because the recommendation is that you do it on all ovarian cancers.
Thank you very much, Professor Zev. Our next speaker is Dr. Asim Amjad. He will talk on image-guided brachytherapy. He is a consultant radiation oncologist in University of Saskatchewan, Canada. And he has been coming on and off to our symposiums. And at one stage, he almost organized our symposium when we did it in Dubai. That was a long time back because it was not possible to do a symposium here. He was at that time in Abu Dhabi, and he helped us a lot in that symposium, and he is always here to help us and our residents, and he's a friend of Shaukat Khanum Hospital.
Yeah, I'm a loyal servant of Shaukat Khanum. I live in a small city, and the day I came to Shaukat Khanum for the symposium, and the night before we collected $100,000 for Shaukat Khanum that day. So all the time. Happy to help in any way. How many of radiation oncologists are here just to see so quite a few. Thank you very much for inviting me. I have to thank Tabinda for the kind invitation. She's a wonderful radiation oncologist and very helpful. I call her from Canada all the time, and she's always willing to help with my patients, and honored to be there with Zeba Aziz here, and Mazhar. Mazhar is my mentor and teacher from back days when we were young. I think 1990, we have the association. 1986, yeah, it's a long time. It shows my age, but what can you do?
My age too.
So I come from Regina. It's slightly colder than here, and glad to be at this time especially. This is our provincial legislative assembly. And you can see it's beautiful in summer, but -10 at the moment in winter, and can go up to -30 sometime in January and February. So glad to be here. Smog or no smog, this is much better. So I'll talk about cervix cancer, and you can interrupt me anytime if I'm sometime I speak or talk too much. I can slow down whenever you need me to. So my talk is image-guided brachytherapy. What it means is that the images that we take during treatment guide us to the treatment. And imaging usually is CT scan, MRI, and PET scan. And this is image guided because initially we give external beam radiotherapy, which is treatment from outside, then internal treatment, which is brachytherapy. During external beam treatment, the tumor shrinks and we have to adapt that shrinkage. And the reason for adapting to the shrinkage is that more dose can be given to the tissues where the tumor is and lesser dose to OARs, which is the organs at risk around it, like rectum, bladder, head of the femur. So adaptive radiotherapy is the way and key to controlling this disease. And you can see from this slide that if you do that properly and your technique is good, you can achieve a good control in about 98 to 100% of patient in stage 1B. You can go up to 93 and 96% in stage 2B, and stage 3 and 4, it can be 73 to 86%. And that translates to about 10% overall survival difference, which is quite a big achievement. And this is with very few morbidities, 3 to 6% of the morbidity to the bladder and rectum. So these are some of the terminologies that we use for image-guided brachytherapy. Gross tumor volume means that this is the tumor, the exact tumor that you see during the treatment or just before the treatment, which can be visible with naked eye with examination or through MRI or CT or PET scan. Clinical target volume is that there is a tumor that is visible, but there could be microscopic disease that is not visible and through the scans, and that subclinical disease or microscopic disease has to be eliminated in order for us to have a good control. And CTV is based, or clinical target volume is based on our past experiences, how much the tumor could be outside where the visible disease is. And usually we extend the border of gross tumor volume by 5 to 15 millimeter to encompass this volume. And CTV in image-guided brachytherapy is very important. We take high-risk CTV, and we take intermediate risk CTV and low risk CTV. And the idea for defining three terminologies is that closer to the tumor, we want to give maximum dose. And as we go away from the tumor, lesser dose would be enough to sterilize the tumor. So HRCTV is the prime target during our brachytherapy. ITV, this is the internal target volume, which is very important because the bladder filling can disperse the anatomy around, and bladder is the main culprit here. So we treat this by taking the images with empty bladder and full bladder and draw the volumes accordingly and create what we call an ITV, which helps us treating this cancer. PTV, then this is another margin we take because of the geometry of how the beams angles are produced. That is something that we use to further enhance our volume. Organs at risk, bladder, rectum, head of femur, small bowel, all that is also outlined. And this is just to highlight that during brachytherapy, we also give chemotherapy, which is cisplatinum, and it translates to a good overall survival. About 18 randomized trials have shown us that in stage 1B and 2A, you can achieve about 10% absolute survival benefit, and goes to 3% if stage 3B and 4, which is quite locally advanced or metastatic disease. So how do our gynae patients come to us to get this brachytherapy? So all the patients that come to our cancer center, they are first tried by our dedicated clinical nurse who's very efficient. The patient is usually sent by the general gynecologist, where the biopsy has been done after the symptoms have been showing, and examination shows a cancer and biopsy has been taken. She books the CT, MRI, and PET on level 2 basis, which means that it has to be done within 10 days. And then she presents those cases in the gynecology oncology tumor rounds, where radiation oncologists, medical oncologists, pathologists, and nurses are present, and we determine what treatment plan we have to go. If the tumor is very small, they go for surgery. If the tumor is big, they go for radiation and chemotherapy. We then do a planning CT simulation for external beam radiotherapy. We prep the patient by giving them bladder and bowel preparation. Bowel preparation is usually for 5 to 6 days. Bladder volume is about 500 cc of water is given to the patient, and MRI and CT and PET are available for fusion to make sure that we do not miss anything. And patient is usually in supine position. What has changed, or what is maybe different than many centers, is that we use a Limbus artificial intelligence program. This was designed by our radiation oncologist and is currently in vogue in many centers as well, where the artificial intelligence software outlines all the lymph nodes, the vessels, and the normal organs. And then it helps us save time, and then we alter it if there is some difficulty. Once these images are drawn through the Limbus, it goes to the radiation oncologist and further volumes are outlined. MRI is key to our treatment planning. We do MRI at the beginning of external beam radiotherapy to outline the topography and anatomy and spread of the tumor. We also do it after the external beam radiotherapy is finished and patient go for brachytherapy or internal treatment to get a qualitative and quantitative information about the tumor in 4D. 4D means that 3D is AP, PA, and oblique views, but fourth dimension is the time there. MRI cervix is done with 4 hours fasting before. Bladder and bowel are emptied. Sterilized gel is used in the vagina. MRI is performed usually about 10 days after the biopsy so that there is no false positive results. And usually we use 3 Tesla Philips MRI scanner. This is the anatomy that we define, and you can see the bladder. If it's very filled, it can displace the tumor. That's why we create that what we call an ITV, where we do images with an empty and full bladder. The same thing. So what are the recent developments in brachytherapy that have gone or made us do a better tumor control? This is because of the use of MRI. We can define the tumor volume much better now. We can use intracavitary and interstitial treatment as well. Dr. Tabinda uses interstitial treatment all the time. I think almost every patient use it, right?
Mainly in bulky disease.
Bulky disease, but most of your cases are bulky, right? Yeah, so very common here. Incorporation of MRI and CT fusion and adapting to the changing volume. This is the key for any junior physicians, that you don't rely on initial information. You have to make sure at each step of the treatment that you look at current images to make sure if the tumor is small, then you de-escalate the dose. If the tumor is larger and not responding, then you have to escalate the dose. So image-guided adaptive radiotherapy, I can't emphasize how important it is to be aware of what is happening. And this is the EMBRACE study. This was a retrospective study done in Europe. About 12 to 14 centers took part in it, and they determined the guidelines. Castro inherited it, and this was a benchmark of image-guided radiotherapy. And it showed us that you can reduce the volume of the tumor outlined by taking use of the MRIs, PET scan, and CT, so you can reduce the dose to the organs and enhance the dose to the tumor itself. There were 2 studies. First was the EMBRACE-1 studies. It incorporated the MRI into our planning system. It showed us that we can categorize tumors according to their control of local control, overall survival, morbidity, and quality of life. And these have to be incorporated and documented. And this is created a reference material for future guidelines. And it showed us that if we are not vigilant, if we are not doing MRIs regularly and not taking care of the imaging modalities that we have, we will under contour the disease. And by under contouring, we will de-escalate the dose and local control would be inferior. And by using these, we can achieve a high level of local control in a smaller volume. And majority of the tumor failure or local control failure is within our target. So meaning that if we under contour the tumor within our defined volume will be less. Embrace 2 then told us that MRI is used for brachytherapy, but also we have to use modern technology and modern treatment modalities for treating the lymph nodes, especially with the IMRT and VMAT. So this is commonly, Shaukat Khanum also uses the same thing, 45 grain, 25 fractions overall with IMRT or VMAT at the beginning. You do the MRI afterwards and then go for brachytherapy. And overall treatment time has to be below 60 days. And there's a clear evidence that overall treatment time is very essential in overall survival and control of the disease. If you exceed 64 days, there's inferior tumor control. So these are the volumes that they were defining, that everything should be documented. For instance, D98 means that dose to the 98% of the volume of the gross tumor should be documented. Clinical target volume should be defined at 90 to 95 isodose line. Bladder should be less than 80 grays and rectum should be less than 65 grays. We adhere to it very strictly. And these are some of the volumes that I was pertaining to intermediate risk. So you can see this is the tumor. The green area is the microscopic disease, and the red area is where you want to achieve the control by giving a higher dose. This graph is based on a retro-embrace study, which showed that if the tumor is more than 4 centimeter, you have to increase the dose to achieve 90 to 95% control. If your disease is less than 4 centimeter, you can reduce the dose. So there's a definite dose volume parameter here. So what we do is we do an MRI at the end of the external beam radiotherapy. We insert what we call a sleeve inside the cervix. It's a tube that goes in and sutured at the external os and gives us a good outline of where the endocervical canal is, where we can insert the brachytherapy. So before the brachytherapy, which is image-guided brachytherapy, which is the topic, we do confirm that what is the current disease status at the time of brachytherapy. This is done with radiologists present. We determine the cranial, caudal, and lateral extension of the tumor. We also determine what's the central tandem, which is the central part of the brachytherapy equipment that goes into an endocervical canal. What's the length of it we need to use, and patient then is put on a lithotomy position. Catheter is inserted in the bladder. We insert the contrast in the balloon, and sleeve then is identified, and appropriate size of the brachytherapy equipment is put in. So usually these are the stages that we use for usually 1B2 to stage 3 cancers are the one that we use for brachytherapy. And in cisplatin continues during the brachytherapy procedure as well, but on day of brachytherapy procedure, cisplatin is not given. So time constraints is, I can't emphasize enough that how quickly you should finish the whole treatment. The benchmark is 60 days or less. It should not exceed. And if you are able to achieve, you will have a better local control and future better overall survival. The patient consents are taken before that. She is well briefed about what is going to happen. The whole procedure is explained in written and verbally, and then the date and time is also fixed. So this is what we are achieving for clinical target volume of high risk disease, which is present at the time of brachytherapy, should have at least 85 gray. CTV intermediate risk, which is the disease that is at lesser risk, 60 grays, which was present at the time of external beam, but at the brachytherapy, it has melted away, but still should get at least 60 gray. And the residual disease that is evident should get at least 95 gray. So, and this can't be achieved, as Tabinda was saying, if you have a bulky disease, unless you are very careful in outlining it and you use both intracavitary and interstitial technique, it would be difficult to manage these doses. And OARs, which is the organs at risk, the bladder should not exceed to more than 80 gray, rectal dose to less than 65 gray, sigmoid colon to less than 70 gray, and the dose to lower and upper vagina should also be mentioned or targeted. How are we doing with time? Okay. High-risk CTV, what is the volume of high-risk CTV? High-risk CTV is the macroscopic spread that you see, which is GTV, plus you outline the whole cervix, plus the presumed extracervical extension and residual disease. That's the high-risk disease. That is what you're aiming at. Intermediate risk clinical target volume is all this, plus safety margin of 5 to 15 millimeter, 5 millimeter around the rectum and bladder, but the rest is about 10 millimeter that we use. And low risk is if the disease is has a microscopic spread further than this area. Intermediate risk CTV, as I said, 5 to 15 millimeter extension around the HR CTV, which is high risk CTV. If you have an extensive disease, which is bulky, and you get a complete remission, your intermediate risk should be the same as high risk CTV plus the GTV at the diagnosis, and no safety margin is needed. If you have a partial response, then you have to include the high risk CTV, cervix, and the parametrium, which is the lateral part of the pelvis around the cervix. And then you extend the margin to outline the PTV. You have to outline what are the organs that you want to save. And it's very important to be consistent. For instance, if you have to draw rectum, it should begin about 1 centimeter above the anus and goes up to the sigmoid flexure and cover the outer wall of the organ. The sigmoid then at the rectosigmoid junction up to the anterior part of symphysis pubis, and bladder should also include the outer wall up to the urethra. In order for us to improve these contourings, we should have contrast placed in the rectum and bladder. We should reconstruct sagittal, coronal, and axial images. We should also identify the uterine vessels so that we can measure the superior border of HRCTV. And MRI images should either be fused. If they can't be fused, they should be available to identify all these targets. And these are the things that you measure. D naught means the dose, there's no dose to these, or 1 cc of the volume should receive how much, and these should be established in your guidelines on protocols. And this again is how you mention the dose to the 90% of the volume, the 100% of the volume. And the limitation is if you don't draw it well and you are not consistent, these volumes would be very difficult to achieve, and you would have inconsistent doses to all these targets. And these are some of the equipment that are available in various parts, in various centers, Ring, Fletcher, and Manchester's type. Applicator placement is placed where there is a central tube. The central part of the tube goes into the endocervical canal, and there is ovoids there. This is ring or ovoids that are at the os. And then there is a rectal spacer, or what do we call that? Rectal retractor that is also used to push the rectum away from it. And this is the same diagram that we mentioned before. So patient is usually very comfortable, immobilized with a vac lock and clamp placed to hold the apparatus together. Once all these things are done, patient goes to the CT simulator where images are taken with 2.5 millimeter thick slices and transferred back to the planning where we draw the CTV and OARs, which is the organs at risk, and then it's planned. We can do this with MRI planning as well. That's where the future is going to be. And we are in process of buying an MRI for this purpose, which can be used for both for diagnostic and radiotherapy treatment as well. The usefulness is that it shows an excellent soft tissue contrast. It is multiplanar. It gives better visualization of the tumor and parametrium. It shows you how much the tumor has regressed, so you can outline your contours accordingly. Disadvantages is it's very expensive. You have to have compatible applicators and all that. But that's where probably the technology is going to. Okay, let's go there. So this is what our plan looks like. Usually the red area is where we are giving the highest dose, and the cooler colors are showing lesser dose to where the disease could be subclinical and does not need higher doses. And this is a patient who was treated, she was treated with the same implants, and 7 years later, there is some enhancement, but she's clear of the disease. Okay, I think that is it. This is the machine that we use, similar to what Shaukat Khanum has for radioactive isotope, and this is our this is a very important spreadsheet that we use. It gives us a real-time information, how much dose after each implant is going where, and making sure that we do not exceed by GAC-Astro or American Brachytherapy Society's guidelines, and gives us a visual inscription of where we need to decrease or increase the dose. Thank you very much for your.
Thank you very much, Asim. It was quite elaborate presentation, and it shows how things have improved from manual loading that we used to do when you were in training with us at that time.
X-rays, we used to do the implant and take an X-ray and hope everything is shrunk and there's no tumor, and whether it moves or not.
The most important thing was that we were doing it with our own hand, cesium implants.
Yeah.
And the distance between the cesium and our hand was, I think, few centimeters. So we are still having our hands and nails.
So question at the end or now?
Do you have any questions?
We can, yeah, if there's one or two questions, we can do it now, or if there's none, we can proceed. And then if any questions comes in your mind, you can always ask us at the end of the.
There must be some questions, right? You can ask about weather. Thank you.
So the last talk for the session is by Dr. Sajid Mushtaq. Dr. Sajid Mushtaq is a senior consultant pathologist at Shaukat Khanum Memorial Cancer Hospital, Lahore, and he will be talking about updates in pathology and staging based on pathological updates in endometrial cancer.
Thank you, Dr. Tabinda, for inviting me. And my title of the talk is slightly different. it is selected problems in gynecological pathology. So I will not be talking about endometrial cancer alone. And basically, I was invited by a gynecological institute in Islamabad a few years earlier. And it's still easy for a pathologist to give lecture to pathologists, but to non-pathologists, I thought that what should I select? So I based my presentation on this thing, that whatever the questions we discussed in multidisciplinary tumor board, I received calls from the oncologist or the surgeons or from the colleagues, where I find that we have some problems in understanding some areas. So I thought maybe I would just talk about few of those. So basically it's oncologists, gynecologists, surgeons, and pathologists. So I would be talking about endocervical adenocarcinoma and difference between endocervical and endometrial adenocarcinoma, genetic types of endometrial carcinoma, Lynch syndrome, adenocarcinoma involving both endometrium and ovary, and then selected problems in mucinous tumors of ovary. So about endocervical adenocarcinoma, there are two main things which I think may or may not be very important from the treatment point of view at this stage, but it's very important to divide endocervical adenocarcinoma into HPV related and non-HPV related. So the current WHO classification divides those tumors into two groups. So whenever you read a report of an endocervical adenocarcinoma, you must see whether the pathologist has done some testing to make sure that it's an HPV related and or not. And this also helps us in exactly subtyping of adenocarcinoma, which may have implications for research and other purposes. One of the major and very interesting sort of thing which came out in endocervical adenocarcinoma in last 6-7 years is that everywhere PT is one of the very important prognostic parameter. But in endocervical adenocarcinoma, they saw that rather than PT, it's the pattern of invasion of the tumor, which provides more important prognostic information. So based on that, there were 3 types of pattern, and I will not go into the details of what patterns are, but basically the pattern is just closely packed glands without real invasion, and pattern C is a widely invasive type of adenocarcinoma. So all the data shows that the pattern of invasion are more important than PT in determining the prognosis in endocervical adenocarcinoma, which is HPV related. So this is why also you should know whether it is HPV related or not. So out of the non-HPV related adenocarcinomas, there are many different types, and I will not go into the details. But one of the names which we all knew was minimal deviation adenocarcinoma. So I thought this name is known to many people, many pathologists and many oncologists. But now, according to the current classification, we call it a gastric type non-HPV related adenocarcinoma. So if you see gastric type non-HPV related diagnosis, this may be a minimal deviation adenocarcinoma. Now, gastric type adenocarcinoma, the diagnosis is based upon the morphology, and you can use some markers also to diagnose it. And as compared to, and this looks very bland, this gastric type adenocarcinoma looks very bland, especially the minimal deviation type, but it is associated with early spread to peritoneal cavity, adnexa, and ovaries. as compared to an HPV type of adenocarcinoma, it is said to present at an advanced stage and behaves aggressively. So sometimes we come across the diagnosis of, I have come across the, I've seen in when reviewing the cases or getting questions from on the oncologist, that there was a diagnosis of serous carcinoma or endometrioid carcinoma of the cervix. Now, if you get a report of serous carcinoma of the cervix or the endometrioid carcinoma of the cervix, please doubt this. This is highly unlikely because the current WHO has completely excluded serous carcinoma from the adenocarcinoma of the cervix. So if there is a serous carcinoma, it has to be of endometrial origin. It cannot be of the cervix. Similarly, majority of the endometrioid adenocarcinoma are of the endometrial origin and they do not arise from the cervix. So if you see serous or endometrioid carcinoma in the cervix, you should think that probably it is arising from the endometrium and not from the cervix. This is one of very common problem which at least we pathologists face, because initially there is a biopsy and the question which we want to determine is whether it is a endocervical carcinoma or endometrial carcinoma. And this becomes more complex if both cervix and endometrium are involved. So common sense says that if the bulk of disease is endometrium, one should think that it is probably endometrium, but this is not true. Bulk of the disease does not determine the origin of the tumor. Now, what we pathologists mostly do is we try to use some markers like P16, which is a surrogate marker for HPV also, and estrogen receptor staining. And P16 is very important. And if we also use CEA and Vimentin. P16, if it is positive, that we think that probably it is of endocervical origin. But unfortunately, this does not hold true in all the cases, because many high-grade endometrioid carcinomas or endometrial carcinomas are also P16 positive. So just on the basis of that, it becomes difficult for us. Pathologists in the past have classically sort of based their differentiation on immunohistochemical stain carcino, embryonic antigen, and Vimentin. And most of the pathologists like me, who are old pathologists, used to believe that these two markers would give us the answer. But all the current papers say that these are highly unreliable markers, so we cannot really differentiate. So sometimes differentiating endocervical and endometrial carcinoma is not easy, but the tools we have at the present are primarily P16, ER, and PR. Now, coming back to the genetic types of endometrial carcinoma. Now, there is a classification of endometrial carcinoma based on genetics. Now, before going into the genetic types of the endometrial carcinoma, the question arises, why do we need this classification? And answer first is that I should tell you our secret, that pathologists are not very good at exactly typing of endometrial cancer, especially the high-grade ones. The conventional histology and immunohistochemistry is the basis for most of these typing of the endometrial cancer, but this can be wrong in 15 to 20% of the cases. And obviously it will have therapeutic implications as well. Now, out of these group, the most important, here we basically genetically, endometrial carcinoma is divided into 4 groups. One is pol mutated, which is DNA polymerase, repairs the DNA. Second is Lynch-associated microsatellite instability, which we will talk in detail a little bit later. Then is MSI stable, and the fourth group is P53 mutated, which is mostly the serous carcinoma. Now, pole mutated is a very, very good example of how traditional histology and immunohistochemistry has very, very real limitations. Now, these pole mutated tumors have been seen to have very good prognosis. Recurrence is very low. They are not associated with lymph node mets or lymphovascular invasion in most of the patients. So they have excellent prognosis. But on conventional histology, they look like high-grade tumors. So when we report these tumors on the basis of histology, we will tell you that these are high-grade endometrioid carcinoma, and you will treat them very aggressively. Whereas this group deserves to be treated less aggressively, and more importantly, the patient needs to be reassured that she has not a very aggressive type of tumor, and the chances are cure are very high. So this is very, very good example where the genetics helps you, and there is no other immunohistochemical other tool to find this group. Similarly, the last group, P53 mutated serous carcinoma, it also has therapeutic implications, very important therapeutic implications to differentiate it from endometrioid adenocarcinoma. As you all based your treatment decision of endometrioid high-grade carcinoma on the basis of invasion in the myometrium and stage. But serous carcinoma, even if there is not much myometrial invasion, needs to be treated with chemotherapy. And in endometrioid, you will not go to chemotherapy if it is not invading beyond a certain percentage. So it is very, very important. So when you are trying to differentiate serous carcinoma from endometrioid carcinoma on the basis of morphology and immunohistochemistry, so you make mistakes. You cannot, most of the time we are using P53 alone, IHC, to make this decision in combination with histology, but there is overlap. For example, even in pole mutated group, which has a good prognosis, even in some of the pole mutated group, P53 mutations have been detected. So I think this histology alone with IHC has limitations, and genetic testing has to be used. I think it is important that it should be used in combination with conventional histopathology. So now shifting to another part of endometrial carcinoma, and this again, I received questions from calls from, and some of the terms are not very clear to some of us. And this is related to when we are doing mismatch repair proteins or MSI or Lynch syndrome. Now, actually, there are three things. One is mismatch repair proteins. Mismatch repair protein testing is done with immunohistochemistry. As you can see, there are 4 markers: MLH1, PMS2, MSH2, and MSH6. Now, this is immunohistochemistry is just a screening test. It is not a confirmatory test, but it makes the screening is required because then it makes the things cost effective also. And similarly, if during the screening test you find that all these markers are retained, you need not go to expensive genetic tests. But the limitation with screening, for example, if you have alone MLH and PMS2 loss, this may be due to methylation and not genetic mutations. And you have to do the methylation testing before jumping to the conclusion that it is a Lynch syndrome or something else. Whereas if there are MSH2 and MSH6 or PMS2 alone loss in screening, the chances are you have to go to genetic testing then to confirm that whether there are mutations or not. The third thing is microsatellite instability. So there are three types of testing. One is ISC protein, then is MSI, which is done with PCR, and the third testing is with genetic, and confirmatory is genetic testing mutational, which can be germline or somatic. Now, taking it further, one of the problems which is very, and again, it is of therapeutic importance, is if both endometrium and ovary are involved by a tumor, so what is it? So then there can be three possibilities. It's a synchronous tumor involving both endometrium and ovary simultaneously, or it is a ovarian tumor going to endometrium, or it is an endometrial tumor metastasizing to the ovary. And in all these three situations, the stage will change. When you are doing the staging, it will change. And obviously, the treatment options will also change. So first is you have to see the type of the tumor which you are looking. If it is a serous carcinoma, now the name serous also, I have seen that name serous carcinoma also creates a little bit confusion. Now, serous carcinoma of the endometrium and the serous carcinoma of the ovary are two different tumors, but the name is same. So that creates a confusion. So serous carcinoma of the ovary is not same as serous carcinoma of the endometrium. Now, serous carcinoma of the ovary is mostly WT1 positive, majority of the cases, whereas serous carcinoma of the endometrium is not WT1 positive. Again, unfortunately, this is not 100% rule, but it holds true in a majority of the cases. So on that basis, and along with morphology and all that, you can make a good guess that whether it is an ovarian tumor. So if it is a serous carcinoma of the endometrium, it's not really a problem to say that it is metastasizing to the ovary. Similarly, if the serous carcinoma of the ovary, you can do ISCWT1 and reach at a conclusion. The problem is with endometrioid carcinoma. If there is endometrioid carcinoma in the endometrium as well as in the ovary, then the question arises whether it is a synchronous tumor or, as I said, one way or the other. Now, over the years, a lot of things have remained as such, but there are others which have changed, and I will go in a little bit into its detail. Now, these are the classical morphological guidelines for recognizing metastatic endometrioid carcinoma to the ovary, which are used by the pathologists. They will look at the size of the ovaries. We'll see whether it's a unilateral involvement or not, whether there is a surface involvement.
We have 5 more minutes.
Okay. So this holds primarily in low-grade endometrioid. All high-grade endometrioid carcinomas simultaneously present in endometrium and ovaries are considered metastasis of endometrial carcinoma to the ovary. So that is very clear. So this is primarily for low-grade tumors. And recently, with the genetic testing, the new data which has emerged, it shows basically that even all the low-grade endometrioid carcinomas are actually metastatic from endometrium to the ovary. But the interesting thing is, the hypothesis is that spread is by two ways. One spread is transtubal, and those patients behave very well. If the tumor goes from endometrium to ovary, you will stage 3 and treat it aggressively. But these low endometrioid, which spread transtubally, they behave very well, and they behave like a low-grade tumor, even when they are present in both sides. But those tumors which spread by lymphovascular or other routes behave aggressively. Currently, we don't have any means to tell which tumor is of which group, but this is an area of ongoing research. So lastly, I would come to mucinous tumors, and I would, again, you can see that there are a lot of criteria. One of the biggest problems in mucinous carcinomas which comes to us is whether it is a primary mucinous carcinoma of the ovary or a metastatic ovary. Now, first thing, many of us believe probably that most of the tumors in the ovary are metastatic. I'm talking about mucinous, which is not correct. Majority of the mucinous tumors of ovary are primary mucinous tumors, but some are metastatic. However, the problem is how to tell whether it is a primary or a metastatic tumor. Now, in other types of tumor, we can use immunohistochemistry to answer this question. But I will not go into details, but just tell you one thing, that in mucinous tumor, you cannot rely immunohistochemistry to differentiate between a primary and metastatic mucinous tumor. And the only way available is to do a proper metastatic workup and rule a primary elsewhere. So that is the main thing. Second problem with mucinous tumor is that sometimes mucinous tumors show a borderline type of histology, which we will call as borderline mucinous tumor. Now, borderline mucinous tumor, as you all know, will be treated with just with surgery alone. But problem is that many metastatic tumors from pancreas or appendix or from the cervix may show a borderline mucinous histology and can be still metastatic. So what I believe is that if you get a report of borderline mucinous tumor of ovary, just before accepting this diagnosis, do the metastatic workup and rule primary elsewhere. Okay. So this is the summary, that in endocervical carcinoma, P16 IHC should be done. To ER and PH16 are good immunomarkers to differentiate between endocervical and endometrial carcinoma, but they have limitations. There are 4 genetic groups of endometrial cancer, and pole mutated, despite high-grade histology, behave very well. Lynch syndrome testing, IHC is only a screening test and not a confirmatory test for genetic for mutations of these genes. Primary versus metastatic ovary carcinoma, endometrioid mostly is metastatic from endometrium to ovary, but there are special problems with low-grade endometrioid which need to be addressed in future. Mucinous tumors, majority of mucinous tumor in the ovary are primary, but you must rule out a primary elsewhere because the treatment would be different. Thank you very much.
Thank you, Dr. Sajid. It was quite elaborate, nice presentation. And if audience have any questions, they can ask now. Dr. Zeba.
We routinely ask you to do IHC, MSI stability or MSI instability colorectal में, and you send us a report. Now that is by IHC, which the report you've sent, right? जो आपकी report आती है, उसपे मैं पूछ रही हूँ, when we have mutation versus DNA methylation में हमारी treatment काम नहीं करती IOs जब हम देते हैं. And that is why the response of IOs is not 100% in CRC, immune checkpoint inhibitors.
In colorectal carcinoma, you can do BRAF testing. That is a surrogate marker for methylation. If you have some loss of screening proteins, and then if you do BRAF, the next step is BRAF genetic testing, which is available. BRAF is surrogate marker for methylation in colorectal carcinoma, but not in endometrial carcinoma.
So should we routinely send BRAF क्योंकि already बहुत expensive हो जाता है
That is, I think, yes, we
Yes,
have to.
we have to,
No,
because-
but it depends upon the type of loss. If, for example, the loss is in all proteins, you need not do BRAF. Yeah. If it is only one or two, MLH1 especially, then you have to do the methylation. You have to do
We
BRAF.
have-
Yeah.
Because otherwise the treatment will
Yes,
not
the
work
treatment
well.
will be very different. Yeah,
अच्छा, ठीक है, I get it now.
yeah,
Thank you.
that's right. I included this part only because you called me once to ask whether it is a confirmatory test or not. It is not a confirmatory test. Thank you.
Thank you very much, all our speakers and people who came here to attend this lectures. And we are concluding the session of Gynae now. Thank you so much.